And it's my great pleasure to introduce Glen Hubbard to come speak to us today. I've known Glen for many years professionally as an economist, so it's a double pleasure to introduce him. He's now the Dean of the Columbia University Graduate School of Business. From February 2001 until March 2003, he was chairman of the U.S. Council of Economic Advisors under President George W. Bush, where his responsibilities included advising the president on economic policy, tax, budget policy, emerging market financial issues, international finance, healthcare, and environmental policy. After he stepped down as chairman of the Council of Economic Advisors, he became dean at Columbia, as I mentioned, and his research spans tax policy, monetary economics, international finance, and corporate finance. Received his PhD in economics from Harvard University in 1983 and has taught at Northwestern, Harvard, University of Chicago, as well as Columbia. And today, the topic that he wants to discuss with us is his new book on healthcare called Healthy, Wealthy, and Wise. Glen.
Great. Thank you. And thanks very much, Hal. It's a treat to see you here as well. And I guess as I listened to Hal's introduction, I thought a couple of things. One, I'm the only person in the room dressed like an investment banker, so you know that I'm from New York. The other is, I'm afraid you all are going to think I've never had a real job, and I want to assure you I have. I was once a tour guide at Cinderella's castle. So if you think the president doesn't talk to people from the real world, you're mistaken. This book was a treat for us to write. I say us because it's co-authored actually with Dan Kessler and John Kogan here at Stanford University. Because in a sense, the problems that we're tackling in Healthy, Wealthy, and Wise are in fact the elephant in the room, if you will, of what's going to be the domestic policy debate in this country over the next 10 or 20 years. Now, why do I say that? Just give you a bit of motivation for why we took the time on the book. And the book is really a long version of an op-ed that John and Dan and I wrote about a year ago. You can just Google the op-ed and get it. That's the one-page version. But I'll give you a longer version in remarks today. What we were trying to do was ask a simple question. Is it possible that in this part of our economy, which is 1/7 of GDP in the United States, that you could make markets work and get two things? One, preserve a lot of innovation that everybody looks to and celebrates in the American healthcare system, but at the same time, lower some of the costs that are leading people to avoid care, high rates of uninsurance, and a lot of policy problems. That was one motivation. The other motivation, which everybody in this room, particularly since most people in this room are substantially younger than Hal and I are, that should really capture your imagination, or at least than I am. I won't say it about Hal, is the fact that 25 years from now, the Medicare program, our old age health care program, could swallow 10 percentage points of GDP more than it does today. That's just terrible. It means as a society we're crowding out everything else we do. It turns out that we cannot talk about the old age health care programs without talking about health care itself. The genesis of the book came from a series of briefings that I did for President Bush where I call them my Econ 101 series, where you have the best pupil in the world, if you're an economist, you have the President of the United States, trying to get him to focus on an economic issue. The topic he'd assigned me was, help me understand how healthcare works as a market, and this set of lectures became the book. We start off in the book by just saying, let's look at the whole American healthcare system, and I knew the President liked Clint Eastwood, and so I started out with the good, the bad, and the ugly. And I said, okay, here's the good. American healthcare is the envy of the world when you talk about innovation. We give a lot of case studies in the book for cardiovascular treatments, for the treatment of depression. Not just drug therapies, but other medical innovations have largely happened in the United States. That's something we clearly don't want to lose as a country. It's not a matter of pride, it's a matter of our quality of life and care. The bad. At the same time as we have seen this great innovation, we've also seen, according to the Institutes of Medicine, misuse, overuse, and underuse of treatments. Medical errors are rife. We wouldn't accept this kind of error rate elsewhere in the private economy, yet we seem to routinely accept it in medicine. We have enormous quality variation across regions of the country. in healthcare. So despite this celebrated story of innovation, got a lot of problems too. And we have some downright ugly. Costs are rising very fast in healthcare. Hal and I were joking before we started that he and I are in the other inefficient sector of the economy, university education. So we'll put that sector aside today and focus on healthcare. Healthcare is a sector where relative prices are rising smartly and are forecasted to continue to rise. Some of that reflects greater quality, and that's something that's okay. But some of it reflects pure waste. That waste isn't just a social bad, it's leading small employers and even some larger ones to drop insurance coverage, and it puts a lot of pressure on public programs like Medicaid and Medicare. So you start out with this situation, oh my gosh, you got this innovation that's great, you've got quality issues that are a problem, and you have people dropping insurance. What can you do? Now, I should be honest with you right at the beginning. Anybody who stands up here and tells you that he or she has a silver bullet to fix health care is lying to you or has deluded themselves. We don't have a silver bullet. What we have is a way to help make markets work and then step back and judge what to do next. And just to whet your appetite for the story I'll tell you over the next few minutes, John and Dan and I argue if you do what we suggest, you could cut annual health care spending in the United States by about $70 billion a year with no change in outcomes. So we're not talking about giving up quality, we're just wringing inefficiency out of the system. The $70 billion doesn't go in a gutter, it goes back to all of us as wages. So we're better off. So that's point one. We could reduce the number of uninsured in this country by between $10 and $20 million without expanding a single program, without a single new regulation, simply by making markets work. And we can do so in a very progressive way. That is, most of the benefits of what I'm about to describe go to lower income families, not to higher income people. So it sounds like a pretty good trick. Now, what do? We start by stepping back and say, okay, we've got this 1/7 of the economy that both the right and the left says, oh, we can't have a market working in healthcare. And the reasons are familiar. They go to information problems between doctors and patients. They go to the structure of healthcare markets. But we, John, Dan, and I start from the premise there's nothing particularly special here. We can make private markets work. So we look for ways in which public policy has perhaps unintentionally frustrated private markets. Now, the book, we go into a lot of them. I just have a few minutes with you, so I'll tick off just a few. One is the tax code. You may not know this, it's kind of a boring story to tell, so I'll give you the thumbnail version. But a lot of the bizarre health insurance system we have in the United States came about from a few tax regulations that happened during the Second World War that were largely allowed to grow. That kind of accident that sounds like just a curiosity in the history books gave us a quite weird system. A second problem we have that I'll go over is the way we regulate insurance markets in the U.S. raises costs and raises uninsurance. Now, surely policymakers weren't trying to make people uninsured, but the actions they did surely did that. The third area that I'll talk about today has to do with competition in healthcare. When I speak to medical audiences, I always have doctors nodding their head with me as I go through how we're going to save costs, how we're not going to use public programs. Then I get the competition among doctors, and suddenly I see faces get tense. And part of the story we tell in the book is that doctors, specialty societies, and hospitals have all been violating competition policy norms in the United States, and those could be enforced to the benefit of everybody. So this is not a particularly partisan book. Everybody gets gored a little bit. Now, we talk about some other things in the book that I'll just mention. I won't have a chance to talk with you about today. How to treat the chronically ill. You know, if you're an AIDS patient or a diabetes patient, that's not really an insurable event. You know, once you're known to have that, you have high predictable expenses. We have another way of trying to use some taxpayer funds to help take care of that. And then we have some programs to generate better information for consumers. But let me talk about the big three with you today. First, the tax code. What does the tax code do here? Basically, if you get health insurance from your employer, you get an enormous tax subsidy. If your employer buys your health insurance, like mine does, like yours I'm sure does, you get that excluded from your income. It is a benefit that is worth something to you. You don't pay taxes on it, even though you do pay taxes on your wages. By and large, if you had to go out and buy health insurance on your own, you would pay for that out of after-tax dollars. When you go to the doctor outside of flexible spending accounts, what you have done is largely pay for that on your own too. Now, okay, this sounds like a silly accounting exercise, but it's not. What has happened is what economists think of as insurance, which typically is catastrophic insurance. In other words, I should bear the costs of routine checkups, going to the doctor, dentist, eye doctor, whatever it is. But what I would worry about is, my older son rides his bike too aggressively and gets hit, I get cancer, or something like that. That's what insurance is about. But that isn't what insurance is about in the American marketplace. What it's really about is prepaid health care. That is, people have very low deductibles. It covers routine and minor things. And the reason for that is pretty obvious. The tax code says, look, if you pay somebody with prepaid health care, you get a tax benefit. If you give the employee cash, if you get a higher paycheck, that's taxable. So of course we have this way. Now why should we care if we're all just collectively cheating the government on taxes? What we're doing is making consumers a lot less cost conscious, a lot less careful in the way they spend their health care dollars, and they're spending a lot more. And we have data in economics from some experiments that the RAND Corporation did some years ago to suggest that if we could move people up into higher deductible, higher copayment plans, we could significantly lower spending without changing outcomes. We have enormous information also in our Medicare program in the U.S. that there's big variation across regions in spending and no variation in outcomes. So it's clear that we're wasting a lot of money. What do you do about it? Now, if I were playing the professor with you, I'd say, here's an easy way. Just take the tax code out of the picture. No more tax subsidy. So the next check you get, you would see the value of your health coverage from your employer, and you pay taxes on it. Economists would say that's the most efficient thing to do. Now, that's not going to happen. There are a number of political pressures we can talk about. I think the probability of that happening is low. So what John and Dan and I propose is the next best thing. Take that tax subsidy and generalize it. So suppose the law of the land were the following. If Google buys your insurance, you get a tax benefit. If you decide to take it as wages and buy your own insurance, you deduct that cost. You get the same tax benefit. If you go pay for the doctor out of pocket yourself, you can deduct that too. So you get the tax benefit across the board. What happens if you do that is that you decide, hey, why do I want this prepaid health care? I don't want to go to the doctor so much. What I'd rather have is maybe a higher deductible plan and have the employer pay me wages instead. So you have a system that automatically pivots toward being more cost conscious. Congress tried to do this recently. There's a thing called health savings accounts that people can sign up for that have $1,000 deductibles or higher. What we argue in the book is you don't have to get anywhere close to $1,000 to have a big effect. And a lot of people who make a lot less than people in this room do just aren't going to sign up for those plans anyway. So getting the tax code right is a huge thing to do. It also doesn't cost very much to expand deductibility. And the reason is, back to one of those Econ 101 moments, if you raise deductibles, employers wind up paying higher wages. Wages are taxed. From the government's perspective, this is roughly speaking, we do the math in the book, a wash. So step one, get the tax code out of the way. Step two is going to sound arcane, but turns out to be a really big deal, and that's insurance markets. If you work for a large employer like you do, or I do, or Hal does, you are in what's called an ERISA covered plan. You're subject to federal regulation. But if you were imagining this new world where you could go out and cost shop and buy your own insurance if you wanted to, you'd be in what's called the individual market or small group market. That's a state-regulated market. And different states load in a lot of benefits that are required in every insurance policy. So what? Well, it happens that policies in those markets cost 15 to 25% more than comparable policies in ERISA markets. So part of the reasons we see higher rates of uninsurance is people are facing very, very high costs. Now, if we were sort of heavy-handed economists, John, Dan, and I, we would just tell states, don't do that. Well, we don't do that. We're competition kinds of guys. So we say, governors, do whatever you like, but we're going to create a new federal market. So anybody who wants in the United States, anybody in this room, could buy in a federal market a stripped-down, simple insurance policy with no benefit mandates. And the competitive pressure from that federal insurance market will discipline states wanting to put in chiropractic mandated benefits, psychiatric, or whichever medical lobby happens to be strong in the individual state. So point 2, you can reduce costs by getting insurance right. Point 3 is about competition policy. We talk about a number of examples in the book of specialist societies really acting to fix prices and hospitals behaving non-competitively. Elsewhere in our economy, we seem to go into a jihad whenever we see monopolistic practices, but in healthcare, somehow we've waved our hands. So we talk about a number of interventions there. Another legal intervention we mention is the reform of the malpractice system in the country. And this isn't just 3 conservatives economists on a joyride. Malpractice insurance basically adds about 10% to overall health insurance costs and really encourages higher rates of uninsurance. So if we do these sets of things, these reforms of the tax code, reforms of insurance markets, and reforms of the legal system, we argue in the book you can bring down healthcare costs substantially. You get gains in insurance, not because you're making people do anything. Nothing here is a mandatory policy. By lowering the cost of insurance, we use estimates from other economists to talk about the number of different people who now will buy insurance who didn't buy insurance before. That's between 10 and 20 million newly covered people. $60 to $70 billion a year, lower healthcare costs. The positive distribution aspects of the plan come about because low-income people, it turns out, spend a lot more out of pocket than high-income people and get a bigger benefit here. We also propose in the book giving some tax credits to very low-income people who don't pay taxes at all. So let me just sort of wind up, starting where I began. The reason I think everybody in this room ought to care a lot about this subject is, one, we're all going to face rising healthcare costs. But if we don't do something about it, the time will come, and it's only 20 or 25 years away, when literally anything else we want to do as an individual or whatever our social goals are as a country are going to be compromised by this healthcare elephant in the room. We are at a fork in the road in terms of thinking about public policy, and this was the reason I chose this subject for President Bush. One of the forks in the road will simply say, expand Medicaid and Medicare and use price controls. That sounds like a seductive way to control costs. As an economist, my counterpoint would be, if you go that road, what you will do is discourage a lot of the innovation that started off the celebration of the healthcare system in the first place. There is an alternative, and the alternative is making markets work. That, I think, is something that you'll see politicians start talking about more. In fact, in a few weeks, when the President gives his State of the Union address, I strongly suspect you'll hear some of the same language there. So like any academic, I could talk all day. Like a good, nice person, I won't. I'll stop here, but I'm happy to chat with you about questions or comments. I don't know, Hal, if you wanted to.
Thank you very much. First. So the format we're going to do is I promised I would fire Glenn a couple of softball questions, and that would open up to the really tough questions from the audience. So first of all, I will say I really liked your story about being a guide at Cinderella's Castle.
It's the only real job I ever had.
Yeah, I had a similar experience. When I stepped down as dean, I thought about getting a real job, but I decided that would be pretty extreme, so I came to work for Google instead. Actually, so on reform of healthcare, one of the issues that constantly comes up is there a model out there that we can look at and say, yes, it would be better if our system were more like Canada, more like England, more like Chile, more like whatever. So the question is there a model internationally that you think is an improvement over the U.S. model that we could move towards? And maybe not in every respect, but at least in some respects or some dimensions.
Well, I think that turns out to be a pretty hard question because I'll tell you, one of the frustrating things about this whole subject is people typically focus their attention on cost. If you look at the share of GDP we spend on healthcare in the United States versus other countries, we're way high. So you could say, well, what we should do is imitate these other countries and lower costs. The problem for that is it's like walking up to somebody and asking them, did your suit cost too much? Well, I don't know. Some suits cost a lot. Some suits cost a little. But the question is value. Did you get something for your money? So the way I would ask the question is, are there ways we could get more value out of the American healthcare system that other people are doing better? The answer to that is surely yes, and it has to do with information technology and information generally. A lot of the errors in healthcare come about from just the lack of use of IT and modern information technology that we would see in every other sector of the economy. But by and large, I think the innovation is frankly better here.
Well, let me pursue that innovation topic a minute. There's a battle shaping up next summer on IP reform, on patent reform, and the two sides in that battle are going to be the IT industry on one side and the pharmaceutical industry on the other side. Because I think almost everybody in the IT industry agrees that the patenting problem has gotten out of control. We're in an arms race where our competition gets junk patents, so we have to get junk patents. Somebody else gets it. You've got a huge set of patents all pointed at each other, and you have really a state of mutually assured destruction. Because patents in the IT industry are kind of a nuisance, and many people would like to see the restrictions on patents increased so that would make it harder to patent bad ideas. On the pharmaceutical industry, on the other hand, patents really play a serious role. It's important, I think, that it's not just a nuisance the way it is here, but it's something that actually does have, I think, in many cases, an important impact on innovation, although that is a debatable point. Do you have any advice or suggestions about how you could maneuver this rather clumsy system to deal with the problems of the IT industry and the pharmaceutical industry in reasonable ways?
Well, first of all, I think both of those are important problems. There's a huge amount of junk patenting going on in IT. On the pharmaceutical side, I think the pharmaceutical industry does need to step back and ask whether the current patent lives make a lot of sense. And I think the government could start by asking whether the rates of return that we're observing in pharmaceuticals offer a sufficient incentive for innovation if perhaps the lives were a bit lower. And the way I've put it to pharmaceutical executives, the counterfactual is not, do you keep a current 20-year system? It's, if Medicare gets to be the elephant in the room I just suggested it might be, you're headed toward a regime of price controls. So you can patent anything you want. But if you head to that regime, are you better off? So I think some reasonable discussion of lower patent lives now makes sense.
So finally, let me ask you about market-based health reform. One issue is that you want to give consumers more choice. And one of the difficulties in giving consumers more choice is when you have an employer-based system, as we do now. Most employers offer one or maybe two health plans at the most. Only the very, very largest employers and some universities will offer more than that. And what happens is they tend to be clones of each other. Alan Enthoven has argued, I think very persuasively, that it would be much better off if you had more variety. You had an employer offering a PPO, an HMO, a managed care, a low-deductible plan, a high-deductible plan, etc. And the question is, well, would your proposal help lead to this greater choice and more flexibility in meeting people's needs?
I think it definitely would, because it would put wind in the sails of the individual market. The reason you don't see an individual market now that's very viable is the demand side and the supply side. On the demand side, the tax code says don't go there. On the supply side, the state insurance regulation makes it impossible really to introduce a lot of variety. So I think those reforms would actually make for better variety there. And frankly, there's no reason the employer should be the unit of pooling. I mean, if it happens that way naturally, fine. But for most of the firms people work in today, that would be an entirely unnatural risk grouping.
And if you look at, Alan argues that if you take a healthcare provider like Kaiser, who's quite big in Northern California and has a very cost-effective health care, it costs them $1 billion to expand to a new SMSA, and they're not really going to do that unless they think they can reach a goodly number of consumers in that market, but they can't reach it now without the cooperation of the employers, and employers don't have much incentive to do so. So it is a problem in terms of really having effective competition in that industry.
I agree.
I think we'll open it up to the floor. So, yes.
So you're talking about tax incentives for individuals by removing that. But one issue that comes up a lot, especially in California, is the issue of illegal aliens. So a tax incentive isn't going to work for them. How do we also take care of other people in the country, you know, the illegal aliens, people coming into this country to work who don't have documentation?
Important question. In the book, what we talk about is first a more general problem beyond illegal aliens of very low-income people who aren't, for a variety of reasons, in the market system. We talk about block grants to governors. Specifically for illegal aliens, we talk about expanding the community health centers program, which has been used a lot in Texas and in California for illegal aliens. I think it's unrealistic to think about shoehorning some of these populations into the tax code. It makes more sense to do a straightforward spending program. Community health centers have been very successful. We've used block grants to governors for years for that.
You talked a lot about increasing deductibles. I thought a large part of the motivation for low deductibles and low co-pays and things like that is to encourage people to have preventative visits to doctors. How do you address that sort of thing? People that will save the button now.
Yeah. Well, okay. The question was about, if I'm encouraging people to move to higher deductibles, is that going to give up on a lot of preventive medicine that people might have been doing? Discourage them from doing that kind of. It turns out that that's more of a folklore argument. When I referred quickly to the RAND experiments, these were, not the kind of studies economists normally do, which is where we just go out and collect data on an actual population and study it. These were genuine experiments of changing deductibles and co-pays, compensating people in wages, and trying to observe the choices they made and then their outcomes. It turns out that in the data that we have, we don't see the shortchanging of outcomes, that most of this appears to be closer to pure waste. The other piece of evidence we have on that is in the Medicare program, where you do have these very large variations in spending across regions that are generosity differences, but no difference in outcomes. So I agree with you that people raise that, and it is a legitimate question, but the evidence doesn't seem to support it. Well, mortality, the extreme version. Incidence of particular kinds of diseases, general health status as reported by individuals, and so on.
Yeah.
Just want to extend on that question. Are there more radical thoughts about investing in preventative medicine? A lot of insurance companies today potentially won't do so because the benefits are many years down the road when that customer might be a patient of another insurance company. So is there anything that we can do as a society to further invest in that?
Of things, and it's a great question. One, in the current employer market, do more to make it easy and encourage long-term contracting. Because you're right, part of the problem is if I introduce some preventive mechanism in my contract, say with Google this year, and I'm an insurer, next year some guy's going to come in cheaper and displace me, and I won't recover that. Encouraging long-term contracting works. If this were more of an individual market, I think that would occur, frankly, more naturally, because individuals would see more of the benefit of that longer-term investment. That's not something we currently see because it's not you, by and large, that's making the choice about your insurance. It's your employer. But again, policy has led to that frustration.
There in the back.
I have a question. 6 years ago, I was visiting here from Holland, where I was studying, and I had to see a doctor. And I called around. The price to see a doctor for just the medical appointment was about $140. This was 6 years ago. And then to get the antibiotics I needed cost like another $80. In Holland, to go see a private practitioner in a doctor office it cost about $20 at that time. That is a full expense paid. That's what it costs. There's no copay or anything. So I found it quite ridiculous, the pricing here. I heard from doctors, private doctors, that the cost of the insurance for malpractice is not just 10%, it's actually much higher than you quoted. What makes me think nothing is going to be able to happen here, nothing is going to happen, is that the health market is not going to change unless we make more profit, because that's how US operates and the market operates. So I don't see how these reforms is going to be embraced by the market, essentially the big corporations we have, and make that happen without actually enabling smaller businesses to go out and do stuff, and that would essentially kill the big businesses. And so I don't think that Bush friends are going to agree to this.
The part about the president's friends at the end, but I'll try to get at the other. You're right, doctors' pricing is insane, and part of the reason it's insane is the elaborate cross-subsidies that they try to do because of the patchwork of insurance systems and public programs. Letting market forces work there would bring more rationalization there. I would caution you about not taking the Dutch example too far. You may know Dutch public finances are a shamble, and part of that has to do with very excessive healthcare spending. So I mean, there's an old saying in economics, one of the few things in economics that's universally true is there's no such thing as a free lunch. And healthcare is just one example of that. I think there are enormous profit opportunities of making markets work here. I guess I would gently disagree with the notion that what we're suggesting wouldn't be profit-friendly. There would be new kinds of insurance arrangements, new contracting arrangements, new pricing arrangements, new uses of IT and information that I think would be very profitable. Who would lose? Old line insurance companies would definitely fight something like this. Specialist societies obviously don't like giving up monopolies that they have. I'm not saying everybody wins, but there's plenty of opportunity for the market.
Could I just follow up with that? On the Dutch example, I think it's important to distinguish situations where you're paying $25 out of pocket, but of course the doctor is getting reimbursed something from the state healthcare system, just as when I go to the doctor, I may make a $20 copay, but he's being reimbursed from the insurance company. Or if you go to a doctor and say no reimbursement from anybody, then the $150 is probably about what the cost is.
If you go to a doctor in the Dutch healthcare system and you have insurance, you pay nothing at that time.
But what does the insurance pay?
They pay for your...
And you pay for the insurance through either your taxes or your insurance payment.
That's what I said. There's no such thing as a free lunch. You can pay for it in a variety
So you have to
of
look at the price the doctor is charging, but you have to look at the total cost of the visit, which is the reimbursement that he's getting from the various sources. Government plans, healthcare plans, or individual plans.
The $20 was the cost of seeing a doctor privately without insurance.
So the doctor received $20 and only $20 is all he got for seeing you.
Yes, private.
That seems very implausible to me. $1 a minute, it's amazing to me that they have people going into medicine at those rates. Anyway, back in the back.
I question your whole notion of care is a market. Firstly, I think it's inelastic in that if somebody gets cancer, immediately their demand becomes inelastic. They're not going to compromise quality for price. Secondly, we all benefit if people don't see doctors because, for example, vaccinations of other people's children benefit our own children. And thirdly, I think we should set it as a national priority that every single American has health care. I don't see anything in your proposal that makes it possible for every single American to have health care.
Sure. Start with the last one. It is exactly the explicit goal of the book that these forces are going to move us toward a system where everybody is covered in the United States, mainly through markets, but I said in answering this lady's question at the beginning, also through a set of block grant public programs that would try to do that. That is absolutely our goal. What we dispute, and I would dispute with you vigorously today, is that expanding public programs alone is a reasonable way to do that. I just don't accept that as an economist. I agree with you on the inelastic demand in chronic illnesses. I glossed over this in the talk. I'll say a little bit more about it now. We view the chronically ill as a serious problem in pure private insurance systems because for the reasons that I mentioned, once somebody becomes chronically ill as opposed to catastrophically ill. So think about the difference between diabetes on the one hand and my getting hit by a car and being laid up for a few weeks on the other. We do need more subsidies and disease management for the chronically ill person. That should come from taxpayers. Taxpayers are largely on the hook for those individuals today. We talk about ways to do that that could still use private markets. So I'm sorry I glossed over that in the remarks, but I agree with you absolutely. Where I suspect we might have a disagreement is I do think that market forces are far more likely to lead us to this world of broader coverage than nostrums about government programs.
I might just respond. This gentleman, you said, we pay a lot for our healthcare, but we have good quality. I think if you go and talk to the average citizen of Europe or even the average policymaker in Europe, they don't admire our healthcare system. They pity our healthcare system. We pay a fortune, and we get frankly crappy healthcare. I don't think our healthcare is better than what they get. And for example, we talk to people in this room, they probably have an HMO. I don't know if you have an HMO, but I'll bet if you do, you don't like it. If you talk to anybody who goes to an HMO, typically don't like it. That's the future of American healthcare. It's very expensive and it's lousy. So I don't see why promoting more of this is going to improve the situation. Frankly, I think you said block grants for the people who can't afford it. Why it makes sense for those people and not everybody else, I don't know. But if we can afford to pay for those people out of everybody else's pocket, why don't we just pay for everybody out of this common pool of money and be done with it?
We're all going to pay for health care somehow. We can do it through taxes, we're going to do it through direct payments, we're going to do it through insurance. So it's a question of what's the most efficient. I think I would join almost all economists in thinking for the vast bulk of this, markets are going to be the most efficient. To those smug European politicians you're referring to, I would ask them about the free riding that they're doing on American pharmaceuticals and innovation that is the health care that they are getting at a lower price that's funded here. I think there's no question that innovation is better in the United States. The legitimate criticism of American health care is can you keep that innovation but lower the costs? Part of that may well involve getting other advanced nations to pay more of their fair share in innovation. Mark McClellan, who now runs the Medicare programs, an economist, when he was the Food and Drug Administration commissioner, worked very hard to try to get more payments out of those same European politicians. So I'm not sure I'd run as quickly to embrace that model, and I doubt that many European leaders would either.
Expenses last year, I had a good insurance, and I'm just curious, the explanation of benefits that you come in, I did an analysis on it. I had like $30,000 worth of stated surgeries and stuff like that. And I mean, my plan is not that great, it's an independent plan, but my insurance carrier paid about $3,000 and I paid about $3,000. A total of about $6,000 was paid to the providers out of the 30. So what I was wondering is, how does that 30, or let's say for a single procedure, a hand surgery, the surgeon fee, or the hospital fee, $5,000. They actually get $400. What is that $5,000?
Well, part of this gets back to the question the gentleman comparing the Dutch system and the U.S. system too. Currently, there's this whole patchwork quilt of prices, very few of which are actually transactions prices on something. They're an attempt to price discriminate and recover from some insurance plans or some patients. If you move to a system where you have broader access to insurance with higher deductibles and more cost-conscious consumers, I think you're going to see less than that. There's no question that current insurance is very difficult to understand. I mean, all of us, when we get our explanation of benefits, scratch our heads and wonder what's going on. That, I think, is in sort of symptomatic of this broader problem.
What is that $5,000 being reported to, or how is my insurance company being subsidized? Where's that number going to? Why don't they just say $400?
Well, because there may be some plan that's paying $5,000, and there may be somebody who's indigent coming in getting the treatment for very, very little. The provider has to cover costs. And so when there's not a uniform insurance system, providers see, okay, this person's got a very generous plan. I'll get this price here. I'll get this price here. And it comes out this kind of crazy patchwork quilt where you don't really know if I'm getting an appendectomy, what's the price of that appendectomy. By contrast, if you look at something like LASIK surgery for your eyes, that's not generally covered by any insurance. You've seen vigorous competition, falling real prices, and so on.
No, behind you.
Well, I guess this is kind of a follow-up to the question of what was my original one. The negotiating power that I have as an individual when I go into a hospital and want treatment, and I have a checkbook and I'm planning on writing a check out for that amount, is very, very low. The situations happen where they'll give me an initial bill for $1,000, and then even though the insurance pays none of it, once submitted through the insurance company, it comes back and costs me $200. What sort of system do you have to remedy that sort of, as an individual, take it or leave it? They don't necessarily need to trade me. There's millions of people out there. Are there consortiums or groups that you can get, bargaining groups for healthcare costs, or do you think competition, even at the individual level, will sort through all that stuff?
I do think it will. In answering you, actually, this gentleman's helpful question about HMOs, I didn't answer completely, so I'll answer the pair as an answer to your question. One of the reasons you see these innovations like HMOs is, again, think of the policy incentives here. We're not going to let the price system work. So the policies are set against letting the price system work. So we're using administrative gatekeeper mechanisms to work as well. That's the HMO structure. That's I deny you coverage for this. I accept it for this. We could use prices to clear markets as well. We don't because we have this particular bias in the tax code for insurance. I do think if you had more vigorous individual and small group markets, you could see bargaining power through things like health insurance networks, other pooling arrangements that do this. Currently, the tax code just doesn't favor those plans. It favors this more administrative mechanism, non-price plan, but it needn't.
About eligibility. Right now, if I'm working for Google, the insurance company has to accept me. If I stop working for Google, or if I were on an independent plan and moved to a different state, I would lose that eligibility, and currently I would have far less choice in the type of insurance that I would have. How are you addressing that question of eligibility for coverage through this plan?
What we talk in the book is, there's several ways people have tried to do this. Some states, including my own state, try to do community rating, and that's bound to fail. So by saying, you've got to post just one price, some people just aren't going to get coverage. On the other hand, you don't want to have insurance companies doing absolute underwriting, so I try to cherry pick and get single young men, and that's all that I feel like covering as an insurance company. What we suggest is the use of some taxpayer subsidies to give what are called health risk adjusters. So if you're coming into this market with identifiable chronic conditions or other things that make you more costly, you get a subsidy. The private insurer then takes you on but gets a partial subsidy. We're currently spending that money in the system anyway. We just feel it's more efficient in this way.
Okay, let's have one more question here.
Part of the cost of the healthcare system is prescription medication costs, right? And the same medicine costs a lot more in the U.S. because the drug company wants to ignore the cost of research and all this stuff. But they're still able to sell the same drug overseas for significantly less, even during patent, while the patent is still in effect. So how do you sort of figure out to get us, U.S. consumers, to pay a lower cost for drugs?
Well, very careful in dynamic pricing of anything involving intellectual property. I don't have to say that to an audience like this. It's seductive to say, why don't we the marginal cost of producing any of this stuff is zero, right? It's the cost of putting a pill in a bottle. How expensive can that be? But you're not going to get the next wave of innovation. Now, having said that, drug companies are probably getting a bit too much intellectual property protection at the moment. So the question shouldn't be price controls on the one hand, but nor should it be the total free market blather of, drug companies need everything that they're getting. The question is, what's the right return? And that's why, in answering Hal's question earlier, I think we need a serious study of that. I'd caution you, as I was answering this gentleman's question in the back, to be careful about international comparisons because there's an enormous amount of free riding going on internationally. And a lot of those costs are just being paid for here. I think the question is more, can we figure out what a more reasonable return is for innovation in drug companies? The political process, for a variety of reasons that are obvious to everybody, namely the lobbying cloud of certain interest groups, has made that a difficult question.
I think that's a good place to stop. Glenn will be here
Okay.
for a few minutes if you want to talk to him or get a book autographed. And thanks again for coming.
Thank you. My pleasure.